Hello everyone, I'm Ishwari. I'm very happy to do this Q&A session with Dr. Watts. Dr. Watts is a pediatric emergency medicine attending in Chicago. So in this video, you will be able to get the answers to all the most common misconceptions and questions that IMGs have with respect to USMLE scores, research, clinical experience, residency, as well as the match. Hello, Dr. Watts. It's really nice to meet you. How have you been?
Hello, I've been wonderful. Thank you. It's so nice meeting and speaking with you also.
Thank you so much for taking the time to do this. It
Of
really means
course.
a lot to all of us.
Absolutely.
Yeah, because I'd sent in like a lot saying that I'm doing this with you, and I got in a lot of questions on Instagram and on Facebook and on all those platforms, and they want me to uh, convey like a lot of questions to you. So if that's
Sure.
okay, I hope you don't mind.
No, I'd be more than happy to.
All right, so I think we can begin with talking about Step 2 CS and then go
Yes.
on with talking about residency application, about the pass fail, and ultimately to clinical rotations and telemedicine.
Okay.
Okay, all right, so let's begin. So I want to ask you, how exactly will the whole match process be like this year?
So we are still anticipating that the match, the final part of the match will proceed as it does or as it has in previous years. Probably the biggest changes, of course, will be the interviewing process, in that all of the interviews will take place virtually. In terms of and also in terms of the application season, of course, it is opened as of June 23rd. Candidates have been available or enabled to access My eras and start their application and start to work on their application. However, the time for programs to look at the applications has been moved to October 15th. So the biggest change is definitely going to be the virtual interview, and typically programs will give virtual tours. So a lot of the information that you would gather about the program, at least physically, on an interview will still be provided. Probably one of the biggest changes and challenges that the candidates will encounter is just being able to get the feel of each program that may be difficult to assess over virtual interviews.
And do you think this could be an advantage to students, or do you think it's just like a kind of like a drawback?
Well, it certainly can be an advantage in a number of ways. It should decrease cost, right? In that students don't have to do as much flying or any flying and hotel stays. So in that way, and that's possibly monies that they could use to apply to more programs. And so in that way, it's definitely an advantage. Also, I think for students who sometimes the interviewing process can be very intimidating when you're in the room with other candidates. Everyone, of course, talks about their experiences, and you're often comparing yourself, and then the familiarity with the program. If some of the candidates have had opportunities to rotate at that location and others have not, that might make the candidate who did not get to rotate or have any experience at that location, at that hospital, it may make them feel intimidated. So at least it will take away some of that, the negative aspects of that group dynamic. Of course, the cons associated with it is, again, not really getting to get a true visceral sense of the program and of the residents. I'm sure the opportunity to meet the residents virtually will be presented, as it often is. A lot of programs may do a night before in-person meet and greet in the previous non-COVID years, and that was really a good opportunity to talk to the current residents in the program to really kind of get their true feelings with with them out of the environment and their hair down and relaxed a bit.
Mhm.
But so I think that might be a bit of an unfortunate disadvantage or change in the program or in the application process this year.
I see. So, and about CS, since we cannot take CS anymore, do you recommend applicants to take exams like the TOEFL or even Step 3?
Well, so step three definitely, and I would recommend that even in non-COVID times, that IMGs having step three. It's just an advantage from a completion standpoint. Not all programs, but a number of programs are requiring step three passage for their PGY twos to progress to the PGY three year. And so of course that is not a concern for candidates who come in already having passed step three. The TOEFL, I think that could be helpful, uh, somewhat. I don't think there is any disadvantage for having some additional support in at least clarifying the mastery of the English language. However, CS, of course, assesses so much more in terms of physical exam skills and patient communication. So I would definitely, I would, if I had to choose between the two, I would highly suggest that candidates complete step three. And TOEFL, sure, but if a candidate chose not to do TOEFL, I don't think that would necessarily stand in their way.
All right, that's fine. There are students who've taken Step 2 CS before this and have not
Yes.
passed that time. Do you think that could be a red flag right now because they don't have another chance of taking it if they're applying for the match this year? How do you think program directors look at that?
So a fail is a fail, right? So a fail is a fail, whether it is your first CS and you passed your second CS, or whether it's a fail on your first CS and you just didn't get a chance to take CS. So I don't think that it is an additional disadvantage since CS is not available. Those programs that will filter out candidates just due to having a fail status are going, that would be the case whether this candidate took a second CS and passed or not. So I don't think it's an increased disadvantage, but there are definitely going to be programs who would not consider that candidate just because they have a fail, regardless of their subsequent performance.
All right. So that's about CS. And as far as residency applications is concerned, what do you think are the major red flags on a residency application? It could be maybe the presence of something or the absence of something, which is just, program directors are just like, okay, that's not good. What do you think those are?
Well, this probably won't be a very specific answer, but probably the biggest red flags are gaps that are not explained or addressed.
Mhm.
Gaps in training, gaps in education, just missing areas of time that have not been addressed. So those are probably the biggest red flags. And so it's not even so much that you have a gap or even a personal challenge, it's the fact that it's not addressed, right? And so that would be the biggest thing. As far as other things that are red flags, just inconsistencies. It's concerning if a candidate did rotate um, at a U.S. Institution or school and did not have a letter from someone stateside or from that program. And so you would want to ask, why is that? You made this effort to come. Why don't you have a letter from that program or that rotation? So that would be, and while it may be a red flag, it just means that that's something that we are looking for a reasonable answer to. So it's not that there really aren't things that are just, this is a hard pass or a hard no. Like, I see this in this person's application and I'm going to say absolutely not. No, it should be something explained. And of course, candidates, just like doctors and postgrads, are all human. So we have had applicants with very challenging personal situations, and they have addressed it and explained it in their personal statement. And these candidates have still subsequently received interviews and also matched. So there really isn't a complete red flag unless there's something that's completely dishonest. That's very easy to find out.
Right. Mm-mm. Do different specialties look at different aspects of the applications?
So all specialties look at all aspects, but in terms of weightedness, yes, the different specialties will weigh things differently. We know traditionally the primary care specialties, while of course step scores are important, they are often not weighted as heavily as subspecialty applications, such as when you think of like classically like general surgery, even OBGYN, those surgical type of specialties. Oftentimes the scores are weighted very heavily. And so, and then after that, pretty much for all programs, the personal statement is going to weigh very heavily. And then, of course, the letters of recommendations, and then whether or not you have research. So definitely more competitive subspecialties, dermatology. Those are going to be areas where research experience is going to be weighted a lot more heavily than primary care specialties.
Okay. And how important are step scores, like in general, for someone who's maybe for a surgical or for a non-surgical specialty? Like, how important are step scores? And does it always mean that if you have a higher step score, you would be matched?
So step scores are very important. Maybe if you thought about like running a race, right? Uh, the where you start at the starting line, of course, is important, but also whether or not you have shoes on is probably even more important, right? And so you can kind of think about the step scores as whether or not you're wearing the appropriate shoes for you to even get to the starting line of the race. So yes, step scores are important. They are important. They are very important. But with that said, that doesn't mean just because you have poor step scores or you have a fail that you can't subsequently match into a residency program. So yes, they are very important, but they are not the end all to make that determination. For example, a lot of students that are studying for whether it's step one or step two or step three for that matter, if you look in the booklet, it gives you content specifications, and and they'll say, whether it's endocrinology or nephrology or whether it's pediatrics or surgery, and they will list out the weight of those particular areas. Well, endocrinology may have a weight of 10%, and nephrology may have a weight of 17%. Now, yes, nephrology is weighted more than endocrinology. However, it's just like a 7% difference. So it's kind of the same thing with step scores. Step scores are probably weighted the heaviest, but it's still a relative percentage difference between the step scores and the personal statements and the LORs. So often students choose to spend an entire year studying and not really doing anything that year but studying. And those are often the students who feel like the step scores are the only thing that matter. And the thought is that if they get a very high step score, then they're automatically going to match. Uh, on the committee, we look at what you were doing during these times, and you are compared to other candidates uh, who have similar applications. So if you have a 240 or a 260 or 280, I don't know, just to exaggerate a bit, and this other candidate has maybe a 240, but you were not doing anything during that year other than studying, and they were doing clerkships, observerships, research, working and or volunteering in a clinical setting, then they are going to be looked at as the better candidate because they were able to get a solid score while managing other things, as opposed to the student who just spent the entire year studying. I mean, yes, if you spend a year studying, you should get a high score. So we want well-rounded candidates who can multitask because, right, in residency, you don't have time off to study. You need to study while you're learning on how to take care of your patients is also your learning for performing on your step 3 if you haven't taken it, your in training exams, and then of course subsequently your specialty boards. So you don't have an opportunity to spend a year studying, and we want doctors, we want candidates that can manage their knowledge, the acquisition of knowledge, at the same time as delivering patient care, because that's what the rest of our life looks like.
Moving on to the chances of being matched, there is
Yes.
also this thing about the prelim year, right? So
Yes.
if a person is accepted into an institution for a prelim year, does that increase their chances of being matched into the same place?
Yes, it does. Absolutely.
Mhm.
Absolutely. So students often want to do in-person clerkships and observerships, which make total sense until COVID, right? And part of that is because they are under the impression they'll get the feel of the program. The program can get the feel of them. They can meet people in the program and possibly better their chances, because yes, relationships do matter in this whole process. And so with the prelim year, you have that advantage times 1,000, because of course you're rotating in a particular department, but you're likely to rotate outside of that department based on your other. If you think of a classic like IM prelim year, right? You're going to go to the MICU, you're going to go to the ER, you're going to be in the various parts of the hospital, and so you're going to meet many people, and that would be a great advantage. And even if the program does not have a spot that following year when you're going to be applying, your network is so much bigger. And if you were really good, if you were, effective, if everyone had great things to say about you, then people in the program will help you to find a spot. So you will have a great advocates for you to get in another program. And it seems big, but it's very small. Program directors meet multiple times a year across the country. There are various meetings, and then we all trained with each other in different disciplines, from medical school or to residency. So yeah, so you will have advocates on your side, again, providing that you perform well, and it would increase your chances of getting a spot at that program or at another program.
All right, that's really nice to know. And it gives a lot of hope to people.
Well, and one other point about that also is that, again, then you are a doctor who has done a year of training, and so in your subsequent application, you are a very different applicant than the fourth year medical student. And so just with that change in that 1 year, you are definitely in a far more advantageous position than if you did not.
Right. And there is this thing about couple match, right? So does
Yes.
that increase or decrease the chance of an IMG to get matched?
It decreases it, and that's not just for IMGs. That's for American grads too.
Okay.
Uh, so the algorithm for couples matching, I mean, it's a great algorithm, and it works out. However, it's going to be very limiting.
I see.
So it will decrease the opportunity to get matched. So I would probably definitely dissuade someone from doing couples match and IMG in particular.
Okay. Thank you. And talking about the USMLE Step 1 being pass fail, so
Yes.
after this gets converted to pass fail, how do you think that would impact an IMG?
I don't think the impact to an IMG will be any different than the impact to an American grad. So the impact will be the same across in that really specialties that, well, pretty much all specialties, but definitely specialties that weigh really heavily on step scores, that they're just going to look at step 2 and step 3 if it's available. So what's going to happen? Unfortunately, humans are creatures of habit. And so it's just going to move the bar that step 2 is going to be that more important.
Right.
Yes. We are not necessarily when we were evaluating applications, the fact that the person is an IMG, of course, we're aware of that. That comes up, but from at least from an initial standpoint, everyone's kind of on the same platform. If you're choosing between an IMG and an American grad, there are many advantages that the IMG has. Often, we are aware that because of the additional challenges of matching into residency for IMGs are often a lot more flexible in terms of location. So we are a lot we're a lot more likely to believe that an IMG, no matter where they're from, where they're currently staying, if we were to rank them for our program, then they're likely to come. They want to be in a program. They're going to come to the program. And they're going to work hard. So I think for the IMG is regarding step scores, it's not so much to think about this is the way I can prove that I'm better than an American grad. It really needs to be, I do need to do very well on step 2 and really shore up other aspects of my application in terms of the personal statement, the commitment to the particular discipline, and definitely adding some sort of, again, research, volunteer work, or work in that clinical setting, because often the IMG is coming oftentimes within a year or two later from graduating from medical school compared to the American medical grads who tend to go straight through.
The next question was about what part of the application would be given more importance if step 1 becomes pass fail. And then you'd mentioned it is step 2 CK scores, right?
Yes, yes.
And moving on to research. Is research necessary for an IMG?
No, it's not necessary. I've seen plenty of IMGs get matched without research. However, it is certainly helpful. And in terms of elevating you, I mean, if you're an IMG with research, that elevates you above the IMGs without research. So, and maybe even some American grads without research, depending on the specialty you're going into.
And about research, does it have to be done in the US, or can we also say we've done research in med school regarding the papers we published while we were at med school? Is that also counted as valid research?
Oh, absolutely, absolutely. Yes. Yes.
Okay. And do you recommend a basic research year before a match, or even like a clinical research year for an IMG?
I definitely would recommend it. If the plan was to do the research, then yes. I don't know that I would necessarily delay applying for the research year. Of course, again, recognizing that cost is a factor. So if that is less of an issue, then I think it's very good. So it's very good to go through the process when you're eligible, because we also know the people from the previous years. You came, you applied, or you applied and you got an interview, and then you're applying again the following year. So if you don't match and you apply again, there's already some familiarity there. So if your plan was not to immediately apply, then sure, do the research year. But I would not necessarily recommend choosing to delay applying just for a research year.
Right. And does the research have to be in the same branch as the specialty, like, or can I have a research paper in dermatology and still apply for neurosurgery?
Well, it's a very good example. So the short answer is no, it doesn't have to be in that specialty. The longer answer is if you're going to apply for neurosurgery, you really should try and do some research that's not in dermatology. That's a neurosurgery. But yes. So no, you don't need to have research in that area. Again, that's going to be depending on the specialties. That's far less of an issue. For the primary care specialties, that's going to be a little bit more particular for the subspecialties.
And does the journal in which the research is published, does the journal matter, or is any journal okay?
Overall, almost any journal matters. Almost any journal is fine. However, I mean, of course, more prestigious journals, item of research that is likely going to be for someone in the committee to come across, right? If it's a more prestigious journal. However, in the grand scheme of things, just having research in a journal, it's that's fine. Yes.
Yeah. And now we can go to like one of the most important sections, which is the clinical experience.
Yes.
Because of COVID, I think there's like a lot of uncertainty with regard to experience, because a lot of people aren't able to go, and a lot of people aren't able to get their LORs, and they're all really worried. And so, yes, there are a lot of questions about this here. So let's begin with how is a clerkship different from an observership, and what do you think is better?
So that's a very good question. So a clerkship differs from an observership in that traditionally, or by definition, a clerkship involves actual patient care responsibilities, actual patient interactions. The clerk is responsible for interviewing the patient, performing a physical exam, and creating or presenting an assessment and plan. And so, classically, that is what a clerkship entails. An observership, traditionally, by definition, is exactly that. You are in the room observing. You do not get to interview the patient. You do not get to perform your own physical exam on the patient or interact at all, and you don't know. You can formulate an assessment and plan, but that would be based on the information that's gleaned from the doctor or provider who interviewed and examined the patient. So traditionally, those are the differences between clerkships and observerships. However, the actual experience that occurs in an observership may be equal to that of a clerkship, depending on the location at the discretion of the preceptor. In the truest sense, typically clerkships are going to be done and only be available to students who are still in school, who haven't graduated. And then once you've graduated, you can't do a clerkship anymore. So they're all going to be constituted as observerships. What happens in an observership will vary based on location and preceptor, but the definition of them will not change. So in that way, so when I from an applicant standpoint, if I read that a person did a clerkship, then I already know this person is someone who hasn't finished medical school yet. Or if I read that they did an observership, I already know this is someone who has already finished medical school. So beyond that, there really isn't a difference. What's going to be really important, because most of the IMGs will do an observership, there really isn't an opportunity for IMGs to do clerkships. And so most of them will do an observership. And the difference is in the teaching and what they're exposed to. And a lot of this I was talking about, it was pre-COVID, because at this point, the American medical students are doing observerships, but they're still going to be clerkships because they're American medical students. So the title of the type of rotation is not actually important. It is more of a delineation of who is where you are in your training. Thank you.
And how much US clinical experience is required in order to get matched, like in terms of the number of months?
Well, before a few days ago, my answer would be, I don't know, because it's different for everyone, but I would suggest at least 2. And then just a few days ago, we had an IMG who had spent some significant time doing research, and she graduated well over 5 years ago, very close to 10 years ago, and had no clinical experience at all. And she did one telerotation, actually, and she reached out and communicated with some programs, and she actually received a job, a prelim year position at a program in the area that she wanted. So prior to that, I would have said at least 2. But now, so it's wonderful, because it's really a testament to IMGs really needing to understand that they are valuable and they are important part of the training and workforce here in America. Whether the message of that has not been clearly sent, it is very true. And so a lot of the ideas that IMGs have that things are stacked against them for coming is not true. So my short answer to your question is 1, at least 1 clinical rotation, telerotation, it will suffice.
Really happy to hear that.
Yes.
And how can students and medical graduates apply for rotations at hospitals, considering the situation right now?
Applying and getting one are 2 different things. I mean, we are not letting non-visitors into the hospital. So at this point, not only will there not be IMGs rotating in the hospital, we still have yet to reintroduce our 4th years into the hospital in a number of states, mine currently. And we are not allowing rotating 4th years, visiting 4th year American students to come to the hospital. So there's no point in applying for an in-person hospital rotation, because pretty much no hospital is allowing it. Due to COVID, we have to minimize and limit non-essential personnel. So our wonderfully essential administrative staff who are essential, are a lot of them are still working from home, and we still are not allowing visitors into the hospital. So families are still there without their, or patients are still there without their families being able to visit. So while I understand the perceived importance and urgency of which the IMGs would like to have a hospital-based rotation, that is not happening, and it's unlikely to happen prior to, at the earliest, I would say summer of 2021, and that would be um, at the earliest, and very, wishful thinking. So right. So really, the only possible opportunity that I would think an IMG would be able to do in person is maybe a few select uh, outpatient offices. And even those, they're not seeing very many patients. And then again, it's the same thing. It's just not safe to introduce um, mobile people, right? People who've come from other areas in the state, within the US, and to allow them into a clinic, into a hospital, and then again, it's really about safety. Everyone needs to be safe, and that includes the rotator, the candidate, who's doing the observership, and it's just an issue of, is it really necessary to put that candidate at risk, and even possibly the patients at risk, um, for the experience, and it is not, that is not going to keep us from choosing or looking favorably upon an IMG or any other grad.
Right. And since we can't get this experience in the US due to COVID, how do you think it will affect an IMG's application if they say that they don't have any clinical experience at all in the US?
Any clinical experience in the US? Well, so again, they will be compared to their peers, and at this point, no one's having any traditional in-person experience. So then they'll be compared to the peers who are doing telerotations, clinical experience, and so really you look at the you look at the application. It's like, well, this person's resourceful. They found a way to still continue their learning, their education, their exposure to the U.S. system during a time where they were clearly not allowed in, but they still found a way to gather that information and gather that exposure and interact and interface with American docs. So that person is going to be looked upon more favorably than the person who just did not. So the opportunity is there. Um, but whether or not that person was in the hospital, it does not matter. It does not matter. And honestly, we would be very suspicious of someone who's saying they were in a hospital of rotating during this time.
Right. And so, since you mentioned about telemedicine, I want to ask you, how much value does a telemedicine rotation carry?
The telemedicine rotation carries the same weight
Mhm.
as an in-person rotation, if probably not a little more, just because it is a more challenging interface to transition into. And so all of the schools, all of the American schools have been focused on effectively training our medical students through a telerotation, telemedicine based platform, with the intention that post COVID, this will very much still be an important aspect of delivery of care and delivery of medical education. So yes, it is. Telerotation is going to look amazingly well. The person with the telemedicine rotation is going to look very well resourced, innovative, and forward thinking in terms of their ability to access and utilize uh, platforms available to them in order to continue to get their experience in their education.
And does an LOR provided for a telehealth rotation have the same importance as an LOR provided for getting hands-on experience at the hospital?
Absolutely, absolutely. The telerotation LOR is an LOR. It is the same LOR, because what recruitment committees are looking for in your LOR is, of course, solid clinical skills, commitment, dedication, good bedside manner, quality bedside manner, uh, being overall a very well-rounded physician with very solid clinical skills, and understanding that from a rotation, a telemedicine based interface, and the unique challenges that presents, that's going to elevate the perception of the candidate's skill set, right? Because you have to really rely on the senses that you have in order to assess effectively the patients and the cases that are presented. So the telemedicine rotation LOR will definitely have equal, if not slightly more weight in terms of the LOR, again, for the reason of resourcefulness and ingenuity.
Okay, that's really interesting to know. And uh, is a letter of recommendation from a telemedicine rotation enough to say that I've got clinical experience while applying for a match?
Yes, yes, and again, so apparently it is. So definitely, with the candidate, the soon to be PGY1 in a couple of days, had not done any clinical experience in over 5 or so years. I think it was closer to 10 years, and her clinical experience was this cellar rotation, and that was all that she had from a clinical experience standpoint. So yes, it is absolutely. And understand, from a recruitment committee standpoint, it is not like we are interviewing people who are graduating from college, right? So even though you're graduating from an international medical school, we still know you're still having medical training there. We don't think you're just, learn the basic sciences and then you go to residency. No, there's still a clinical training aspect that comes with it. And we are also aware very much that plenty of IMGs have very, very solid clinical skills as part of their training. And the post-grad IMGs that I've interacted with, we talk all the time about, how, based on the countries that they come from, they're so busy seeing so many patients, even in a training standpoint, that they don't get to do preventative care. I've got 30 patients and it's just me and my senior, and that's it. And so we are very much aware that IMGs, as trainees, come with very, very solid clinical skills from a fundamental standpoint. Really, it may be some technological access, when to order imaging studies that we may have a little bit more access to stateside versus not, preventative care. That some of those are the areas where the adjustments have to happen, or even just in terms of, fewer or more end of life issues. There may be conditions that we are more aggressive at treating and saving that may not necessarily be prioritized in a more stressed healthcare system. So those are typically the differences that the IMGs have to adjust to. It is definitely it is really not usually a physical exam, clinical skill, clinical assessment standpoint. So yes, a telerotation is definitely enough to show that you've had some clinical US experience.
And are there IMG friendly institutions that offer telemedicine rotations?
So that's a very good question. So right now, most of the institutions that train residents train medical students, or have a relationship with the medical school. And at this point, all of these institutions are prioritizing the medical students of the schools of which they come from, of which they have the relationship with. The telerotations that are being offered are pretty much in conjunction from that medical school, uh, and the institution that they have the relationship with. But most of the bulk of the rotation aspect is being developed by the medical school. So when we think about it from the residency program side, that's completely different. The priority of the residency program is to train its residents. So the residency program is not focused on developing a telerotation for students.
I see.
So the telerotations that are institution based and sponsored are from the medical students, the medical schools for their students. So, but residency programs that are IMG friendly are definitely open, embracing, and welcoming of IMGs participating in telerotations, uh, for sure. But no, they would not be the ones that are sponsoring the rotation.
Okay. And since you are a preceptor for a telemedicine rotation, there are a few questions regarding how the rotation would go about.
Yes.
So, how many patients does a student get to see on a daily basis?
So that certainly varies. So the delivery of the telerotation varies between, not only between specialties, but even between physicians. So there are some formats that will where there are opportunities to do interviews with patients from a telemedicine platform. There are some formats that include videos of patients that have been interviewed and or examined and walked through. And then there are formats that may just even include conversations over the telephone. Delivery of care side, as physicians, we have to be prepared to deliver this care through whatever device the patient has access to. So it definitely varies, and this is one reason why this is so exciting from a healthcare standpoint, in that we really are fashioning our way of delivering care based on the patient, what the patients need, and patients access.
Right. And Is there an opportunity to interact with patients, or is it just a case discussion during your telemedicine session with students?
So again, it varies based on the rotation. Some physicians who have patients that come in the office, there's definitely an opportunity for the rotator to interact. And then some physicians who are primarily hospital based, where there really is not an opportunity to have a video system, um, uh, appropriately HIPAA compliant, um, there for the students, then those may be case based discussions. And then the rest of the telerotation, of course, is still didactic lectures that are included, as well as quizzes and the same components of what a rotation would entail.
Will an LOR obtained on a telemedicine rotation mention that it was done on, it was done online and not at a hospital?
So typically the content that would be in a telemedicine rotation is going to be the same content that you would get on an inpatient rotation. Now, there definitely is a need to mention that there was a telemedicine aspect to the rotation. And part of that is because, again, we know during this time that no IMGs and really no one other than third year medical students maybe are going to be in the hospital. So of course there really isn't an opportunity I mean it would be dishonest to try and give the presumption as if the entire rotation did not have a telemedicine aspect to it. And that would also actually be at a disadvantage because, again, having a telemedicine rotation as part of the list of the litany of skill sets that you have to deliver care is certainly looked positively upon. LORs are important to speaking to the candidate's character and ability and skill set. And those things can be gleaned through a number of interactions. Those are not limited to being gleaned through you took care of this patient with me. We think about how important the dean's letter is. The dean's letter is very important. The dean likely has never had a patient with any of the candidates that they're writing the letter for. So yes, the telerotation. So it is possible and it is likely that the telemedicine aspect of the rotation would be mentioned in the LOR. However, it will be mentioned as, again, this is a method in which you see this candidate's bedside manner and ability and skill set shines through in a challenging platform that is new to delivery of care.
And what is the cost of a telemedicine rotation?
There is some variation based on the length of time, right? So you are offered telemedicine rotation of varying lengths, but overall, from a dollar for dollar, it is comparable to an in-person rotation cost.
Okay. Moving on to LORs. Is a 3-year-old LOR acceptable, or does it have to be a recent one?
Well, for example, if we took this out of the medical arena, and if you were, I don't know, interviewing or just assessing someone for a dog walker, for example, and this person, you want them to walk your dog or even your babysitter, right? And you're like, well, can you give me a reference? And they'll say, sure, I'll give you this reference from 3 years ago. It's like, well, was that the last time you were babysitting? No, I've been babysitting for the last 3 years. I've been walking dogs for the last 3 years. Yet you don't have a reference from any of the families that you have dog walked or babysat for in the last 3 years, that is not a person that is would be highly considered, because I want to know why. If this is something you've been doing for the last 3 years, why don't you have someone recently who could speak for your skill set? So the same thing. If you have letters from 3 years ago and you're applying now, there's going to be a lot of questions that come up as to why that's the case. So yes, you need at least one recent, at least one. I would say if you've been out 3 years or your LORs 3 years ago, you really need to have probably all recent LORs within the last year for this application. Otherwise, you kind of shooting yourself in the foot.
Right, that makes sense. And does an unwaived letter of recommendation carry any weight at all for an IMG?
It's not really. It doesn't. So whenever we see an unwaived letter, that just means, worst case scenario, the student wrote the letter and asked someone to sign it for them. So it doesn't. I mean, the whole concept of waiving a letter is is basically, it's a trust factor and an honor code. And uh, we would the assumption is that you have requested a letter from someone who could write you a strong letter of recommendation, and that's how it should be requested. And the person, the preceptor, the letter writer, should be confident and honorable enough themselves to be honest as to whether or not they can write you a strong letter of recommendation. And so there's really no reason that a candidate should see their letter of recommendation. So no, you should not have an unwaived letter of recommendation. And with technology in the portal, there's really no reason to have the candidate need to see the letter. It can be uploaded. So yes.
All right. And since COVID has brought everything to a standstill, like a lot of students will be graduating later than expected, including me as well. So, do you think residency applications would be on a rolling basis next year?
No. No, I mean, so the residency applications, I mean, it's a tight schedule. We're on a tight schedule. We need everyone to start July 1st and to finish up at the end of June. So there's not a lot of wiggle room for having rolling applications. Yeah, I mean, there may be some leniency regarding submission of scores and what scores you have available at that time. Um, yeah, but as long as your school, your institution, can certify one you're getting ECFMG certified, but also that you are definitely going to graduate at the indicated time, that isn't enough time for you to start a residency, on July 1st, then that'll be fine. So, but right, there's not a lot. There can be some adjustments in the dates, but the dates have to be solid in the interviewing process. We need and the match, so we still have to stick to a schedule.
Just to clarify, if the last date of submission of the documents is around October, and if the candidate graduates in November or December, they wouldn't be able to apply for match that year, right?
So no. So the last day of submission. So October 15th is the first day that the programs can start looking at the applications. There is no last day until interview season stops.
Okay.
So yes, and so you could start your application as long as your school, as long as your school and you're going to graduate November, December. That's not a problem, because most uh, the American students aren't graduating until June, and the interview season is happening their whole fourth year. So you don't need to have graduated to participate in the match process, because that's not even the typical schedule. But it's just, yeah, so graduating November and December, you're actually graduating ahead of when the American grads would graduate. So that's fine. But right, so those dates, that date is just the earliest the programs can start looking at applications. It is not the end of the application process.
Okay. All right, then. Thank you for that.
Sure.
And a lot of people have asked you for your personal advice for them. And since surgical specialties are a little more competitive, what is your advice to IMGs who want to get matched to specialties like obstetrics and gynecology and other surgical specialties?
My advice is to understand that there is certainly more ways to get to where you want to go to than what may be a traditional linear path. And if that is what you really want to do, then you take the roads that you need to take to get there. Of course, you can apply. I don't think there's anything wrong with applying, but again, cost is a factor. And then, of course, if you don't match, there's, of course, the psychological factor that you'd have to overcome. So, but beyond that, the advice would be really consider doing a prelim year, really consider doing a primary care specialty that is where there are a lot more programs, right? Because basically what makes a program, a discipline competitive is it's supply and demand. It's the number of programs and the number of applicants. So the fewer programs are going to be more competitive because there are going to be more applicants. And again, you'll be compared to other fourth year medical students, people who are recently graduated, or that don't have any official U.S. residency training. So should you do a prelim year or do a year in almost anything, when you're applying again, you are a far different candidate as in 1 year PGY1 internal medicine resident who's applying now to do surgery or OB, as opposed to someone who's had no training. So my advice would be to be very open and creative in terms of getting there. You can do multiple residencies. You can do fellowships. I just had this conversation with one of my telemedicine rotation candidates who was very interested in pediatric surgery. And he stated that he'd apply to pediatrics because that'll get him to surgery, to do ped surgery. And I said, no, and that's fine. I love pediatrics, clearly, but you need to want to do surgery as your passion, and then pediatric surgery secondarily. Your love has to be operating on anything and anybody, and then having a particular interest in pediatrics, not that you're interested in pediatrics and then ultimately you just you want to open kids up. So you really need to think about what the basic part is. I am a pediatrician. I love pediatrics. So I do pediatrics in an emergency department. I'll do pediatrics inside the hospital. I'll do pediatrics at the clinic. I'll do pediatrics in the neonatal ICU or the pediatric ICU because I like pediatrics. And so that's the same thing. If you like OBGYN because you like delivering babies or gynecological surgery, then it's like, okay, where can I get this experience? Well, you could do a year or so of family medicine. You're going to get OB experience doing family medicine, and then decide to transition and apply to OBGYN as a PGY1, or 2 post-grad family medicine resident. And again, that's far more you'll be far more skilled and far more competitive, and you have a bigger network. So what programs are having, someone's leaving. People leave programs all the time. Their spouses got matched somewhere else, or they had a job change, things like that. And so that's also information that you have access to.
Right. And in general, what advice do you want to give IMGs as a concluding thing?
In general, honestly, I would say that probably the most advice is for the IMG to really take ownership of all of the wonderful experiences and skill sets and uh, unique aspects of their medical education training, cultures, and personalities, and formulate that into how that they can use these things to impact their delivery of care to US residency programs. Because if the IMGs come from that standpoint of, this is what I have to share, this is what I have to bring, this is why I'm valuable to your program, I feel like they would have a far better um, opportunity and a far better experience and likelihood of matching. So many of the IMGs that I educate, train, advocate for, even work with, um, have this kind of stigma of, oh, I'm an IMG, please let me in, you're doing me a favor. And while I'm not saying be cocky, do not be cocky, but understand that you do have a very valuable skill set, and you are not anyone's second choice, or second best resident. So bring that passion and enthusiasm that you had to pursue medicine in the first place, and just deliver that and let it shine. Do not let the IMG title in any way be negative or perceived as a disadvantage.
Thank you so much. Thanks
You
a
are
lot
so
for
welcome.
this. It was really nice talking to you, and I'm sure this will help a lot of IMGs.
No problem. It's definitely. I really
Thank
enjoy this.
you.
I really hope and want to be helpful, and this is great. We definitely need the help and the skill set. So good luck to everyone. And hey, if we don't see you after this match, everyone stay safe. We'll definitely see you in the following year or so.
I really hope this video was helpful. Please give it a thumbs up to show me your support, and feel free to share it with all your friends. And subscribe to my channel for more USMLE related content. Thank you.